Our today's lecture is about the ultrasonography of parathyroid gland. We will look at the basic guidelines that we follow to assess the parathyroid glands using ultrasonography. Then we will also talk about the importance or role of the nuclear medicine and ultrasonography for the assessment of different thyroid disorders, and we will also discuss some of the most commonly found anomalies or disorders related to the thyroid gland. So first of all, we will start with the parathyroid glands, and we will talk about the normal sonographic anatomy, the anomalies related to it, and also the anatomy and a bit of physiology of the parathyroid gland. So starting with the anatomy, as you can see that these are the two pair of oval shaped glands, and these are located within the thyroid capsule, and they are usually located, these glands can be ectopic, but they are usually located adjacent to the posterolateral surface of the middle and lower regions of the right and left lateral thyroid lobes. As I have stated earlier that these can be found ectopic, so approximately 10% to 20% of the time these glands can be found anywhere in the paramedian area, which is between the mandible and the mediastinum. If we talk about the size of the parathyroid gland, then the normal gland is approximately 5 mm in length, 3 mm in width, and 1 mm in thickness. Also, if we talk about its physiology, then you know that these glands basically secrete the parathyroid hormone, and this hormone increases the blood level of calcium by promoting the release of calcium from the bone, and it also regulates the phosphorus metabolism, and it increases the calcium reabsorption by the renal tubules. Now we will talk about the guidelines, the practice guidelines for the assessment of parathyroid glands on the ultrasonography. So whenever you perform the parathyroid gland, just remember that it is difficult to visualize the normal parathyroid glands. Whenever you will be able to visualize these glands, then that means its size is enlarged, or there can be any pathology. That's why you are able to visualize it in ultrasound, although the normal parathyroid gland is not easily visualized on ultrasound. So what our practice guidelines say, we will now discuss about these guidelines. So the patient should be in the supine position. Once again, we will be using the high frequency probe, and you can very well visualize these glands using the high frequency probe. The examination should be performed with the neck in the hyperextended position, and you will definitely take the longitudinal and transverse images, and the probe, the maneuvering of the probe should be from the carotid arteries to the midline, and extending from the carotid artery bifurcation superiorly to the thoracic inlet inferiorly. So that will be your approach when you will be scanning for the parathyroid glands. As the parathyroid glands may be hidden below the clavicles in the lower neck and upper mediastinum, it may also be helpful to have the patient swallow during the examination with constant real-time observation. And if you are suspecting the parathyroid glands in the upper mediastinum, then you can image it with proper probe angling under the sternum from the sternal notch. As I have stated earlier that it is usually not possible for us to visualize the parathyroid glands on the sonography. To visualize them, you basically need a very high frequency probe that is not applicable clinically. So with available sonographic technology, you cannot usually see the normal parathyroid gland. Although you can visualize the enlarged parathyroid glands, So whenever you see the enlarged parathyroid gland, then you should note the location, the size and number, and you should document them, and you should also take the measurements in the 3 dimensions, just like we studied in the thyroid gland. Okay, now we will also talk about the appearance or the um, uh, color Doppler or the power Doppler assessment of the parathyroid gland. So just remember that although the spectral color or power Doppler ultrasound can be helpful, and sonography is also very helpful for the guidance of aspiration, or for the biopsy of parathyroid abnormalities, or for the biopsy of any mass present in the neck, or for the interventional procedure. And whenever the parathyroid gland is enlarged, just remember that it is best to assess it in the sagittal scans between the lateral lobe of the thyroid gland and the longus colli muscle. For the normal parathyroid glands to be visualized, we basically need high resolution arrays and the better processing and the 3-dimensional technology, and only then we can be able to visualize the normal parathyroid glands. And the normal parathyroid glands are small, and they are 3 to 5 mm, and we can identify them only with high frequency transducers, as I have already stated that, which is currently not employed. Okay, now we will compare our 2 modalities, the nuclear medicine scan and the ultrasound. So just remember that, as I kept saying, that ultrasound is a very good modality to differentiate between solid and cystic lesions. In nuclear medicine, we can determine the thyroid function, and there are 2 tests as we already know. We perform 2 tests for thyroid scanning, and these are iodine uptake scan and the thyroid scan using the technetium 99M. And for an iodine uptake, we basically give the patient a capsule which contains a small amount of radioactive iodine, and the patient ingests it by mouth. And in comparison with the normal thyroid uptake, the patients who have hypothyroidism, they would have a higher percentage of radioactivity in the thyroid gland, and a lower percentage of the radioactivity will definitely indicate the hypothyroidism. So the thyroid scan will detect the amount of radioactive tracer, and it will demonstrate the thyroid size, shape and its position. So in this figure you can see 2 images, and in image A you can see the hot nodule, and in image B you can see the cold nodule. So we know that if the thyroid has a concentrated amount of radioactivity, that means that area on the image will appear as hot or hyperfunctioning nodule. And on the other hand, if an area of the thyroid have lower concentration of the radioactive tracer, then that area will demonstrate absence of uptake as cold or non-functioning nodule. So in majority of the cases, just remember that 80 to 85% of the nodules in the thyroid scan are demonstrated as a cold nodule, with the remaining 15 to 20% seen as a hot nodules. And the cold nodules could have the potential to be malignant, but later when we perform the fine needle aspiration biopsy, it does not show any malignancy. The other modalities that we can use to assess the thyroid anomalies, these are the computed tomography and magnetic resonance imaging, and we can determine the thyroid size, its shape, its position and imaging characteristics of the masses that can be found within the gland and the neck area using these modalities. But just remember that the sonography, the role of the sonography is to determine the solid or the cystic nature of a core nodule. And we can also later on use the fine needle aspiration biopsy to confirm the nodule to be benign or malignant. Now we will talk about the nodular thyroid disease, in which first of all we will talk about the nodular hyperplasia or multinodular goiter. So there can be various causes, but we know that approximately 80% of the nodular thyroid disease is due to the hyperplasia or the compensated hypertrophy, which can form the micronodules and macronodules of the gland, and these can lead to overall enlargement of the goiter, or we can see multiple nodules that can be unilateral or bilateral. And the gender also plays a very important role. These nodules are most commonly seen in the women with increasing age, and when we evaluate these microscopically, most of the benign nodules are classified as hyperplastic adenomatous and colloid-type nodules. And the most common cause of the thyroid disorders worldwide is due to the iodine deficiency, which can lead to the nodule and the goiter formation. Okay, now we will talk about the sonographic appearance, but before that I would like to also highlight the clinical findings that can be associated with the multiple nodular goiter. So whenever the clinician palpate an enlarged thyroid during a physical examination, a goiter may become very large, that can compress the esophagus, and the patient would have dysphagia, and the patient can also have pressure on the trachea or the neck veins. The pressure on the neck veins will definitely lead to the venous distension, and it can also cause the hoarseness of the voice. So the patients may also present with clinical symptoms of hypothyroidism or hyperthyroidism. Now I will talk about the sonographic findings of the appearance of nodular thyroid disease. Okay, first of all, it can vary, as this image is showing the appearance of the nodular thyroid disease in two different patients. You can see that it is diffuse in image A, and in the next image you can see the vascularity of the thyroid gland. So just remember that the nodular thyroid disease can vary. There can be diffuse symmetrical gland enlargement, or there can be localized discrete nodules. Okay, I am repeating it. The sonographic appearance of nodular thyroid disease can vary, and you can see the diffuse symmetric gland enlargement, or you can also see the localized discrete nodules. So enlargement can involve both lobes, and isthmus can also be involved in enlargement, and there can be several nodules described as multinodular goiter. And these nodules can also vary in echogenicity, and these nodules can be isoechoic, hyperechoic, and complex cystic due to the fibrosis or due to the focal scarring, ischemia, or they can be cystic degeneration or calcification formation. So there is a variety of sonographic findings that we can assess while evaluating a thyroid for nodular thyroid disease. I'm repeating the main points again. Whenever you find a nodular thyroid disease, it can vary. It can be diffuse symmetric, there can be a diffuse symmetric gland enlargement, or there can be localized discrete nodules, and the enlargement can involve both lobes and also isthmus, and you will find various or several nodules, and we will describe it as multinodular goiter. And the echogenicity of the nodules can also vary. These can be isoechoic, hyperechoic, or complex cystic, and this can be due to the fibrosis of the nodules, due to the focal scarring, due to the ischemia, due to the cystic degenerations or the calcification formation. And another important thing is that the vascularity of the diffusely enlarged thyroid gland, as you can see in the image B. Okay, that's how a colloid nodule, a thyroid colloid nodule will appear on an ultrasound. This one is, there are 3 hyperechoic nodules you can see, and there is a typical hyperplasia of the gland. In this image you can see the cystic changes within the nodules, and there is a extensive honeycomb like appearance, or the cystic changes within the nodules. So these all are the different appearances of the nodules found in the nodular goiter. Okay, this is another slide which is showing us the inhomogeneous enlarged tissue mass within the thyroid gland, and in the image B you can see that there is an increased vascularity in patient with the multinodular goiter, and there can be calcifications in a nodule as well. Now I will discuss about the thyroiditis, and this is an image which is showing the Doppler appearance and the normal B mode appearance of the thyroiditis. So thyroiditis is basically a group of disorder that causes the inflammation of the thyroid gland, and there can be several causes. It can be due to bacterial infection or the viral infection, or it can be related to the postpartum or the post-radiation ablation technique. It can be due to the autoimmune abnormalities, and these all causes can result in hypothyroidism. So there are types of thyroiditis, which can be acute thyroiditis, subacute granulomatous thyroiditis, which is also called the Quarian's disease, and the chronic lymphocytic thyroiditis, which is Hashimoto's disease. So we will talk about the chronic autoimmune lymphocytic thyroiditis or Hashimoto's thyroiditis, and the de Quarian's disease, which is the subacute granulomatous thyroiditis. We will focus on these two types of thyroiditis. So the first one is the Hashimoto's thyroiditis, which is the most common form of the thyroiditis, and it is associated with a destructive autoimmune disorder which can lead to the chronic inflammation of the thyroid. And the clinical feature which is associated with with this type of thyroiditis is a painless, diffusely enlarged gland, seen most oftenly in the young or middle-aged women, and it is characterized by moderate symmetrical enlargement, mild hypothyroidism, and there can be a presence of serum autoantibodies against the thyroid gland. So sonographically, as you can see, and this will appear on the grayscale as a diffuse coarse parenchymal echotexture that will generally be more hypoechoic than a normal gland in characteristic. As you can clearly see in the image here, that the mass that we are seeing is hypoechoic than the normal gland. The gland is usually large, but it can be normal. There can be distinct nodules present, and on the color Doppler you can see that there is a marked hypervascularity present. So these are the sonographic characteristics of chronic or thyroiditis or Hashimoto's thyroiditis. Okay, now we will talk about the subacute thyroiditis. The subacute thyroiditis or Deke variant thyroiditis is believed to be caused by a virus rather than the autoimmunity, and it is also more common in women, and it can result in diffuse inflammation of the thyroid that can lead to dysphagia, fever, pain, tenderness, enlargement, and malaise. The disease can subside within few months, but during that period, the decoherence thyroiditis can cause transient hyperthyroiditis, or hyperthyroidism. But the normal function will return within few months. Now we will talk about the sonographic appearance of subacute thyroiditis. As you can see, the gland is appearing heterogeneous with both hyperechoic and hypoechoic nodules. So you can find a heterogeneous appearance of the gland. There can be both hyperechoic or hypoechoic nodules, and there will be an overall decrease in the parenchymal echogenicity. And when we will perform color Doppler, then we will observe that there is decreased vascularity. There can be normal or decreased vascularity. Although on chronic thyroiditis, we saw that there was a marked hypervascularity present on the color Doppler. But in subacute thyroiditis, we are seeing the decreased vascularity, or the normal pattern can also be observed. In this image, you can clearly see the decreased echogenicity of both lobes, and this is the color Doppler assessment of the subacute thyroiditis. You can see that there is decreased vascularity within the area of thyroiditis. Okay, now we will talk about the adenomas and carcinomas. So there is a benign tumor which is known as follicular adenoma, a benign tumor of thyroid follicles, and usually the adenoma is solitary. It is well encapsulated lesion, and the remainder of the gland will appear normal, and it is 7 times more common in females than in males. So far, the disorders related to the thyroid that we have discussed are most commonly found in females than in males. Occasionally these adenomas can be hyperfunctioning, and these can result in hypothyroidism or thyrotoxicosis with suppression of the rest of the gland. These hyperfunctioning adenomas, when we will assess them on nuclear medicine, these can result in port lesions on radioisotope nuclear medicine scans. Although on sonography, as you can see in this image, that the adenomas are solitary, the solid homogeneous lesions, and they have regular smooth margins, and they have an oval or round shape, and the echogenicity can vary, although the adenomas can appear hyperechoic, isoechoic, or hyperechoic to the normal thyroid tissue, and they can also undergo the cystic degeneration. You can also observe a peripheral halo around these adenomas. Okay, now as you can see that there are 3 images showing the adenomas, and in the image A you can see there is a solid hyperechoic nodule with thin peripheral hyperechoic halo, and in the image B you can see there is a solid isoechoic nodule with a peripheral halo, and in image D you can see another isoechoic nodule with a peripheral cystic area. So these are the different appearances of an adenoma. Okay, now we will talk about the carcinomas. The first carcinoma that we are going to discuss is the follicular cancer. This is an appearance of follicular cancer on sonography, and the follicular cancer basically accounts for approximately 10% of the malignant thyroid nodules, and this is also common in women as compared to men. And these can spread, or they have metastatic spread to the bone, brain, lung, and liver. The sonographic features are more or less similar to the benign follicular adenomas, but malignancy should be suspected with the presence of thick irregular halo, and whenever you observe a tortuous internal blood vessels with increased vascularity, you should always suspect malignancy in that case. And you will also observe cervical lymphadenopathy in case of malignancy. These are although not specific for follicular carcinoma, but you should suspect whenever you see these characteristics. So this is an appearance of follicular carcinoma, which is showing a solid, smoothly marginated nodule with a partial halo and several cystic areas. Okay, now here you can also observe a solitary lesion, which is representing a follicular carcinoma on biopsy, and in the image B you can see that there is an increased vascularity within the mass. Next cancer is the papillary carcinoma, and the papillary carcinoma basically accounts for more than 75% of the thyroid malignancy. It is not uncommon to find small foci of papillary cancers in the surgical specimens of the thyroids removed for other benign nodules. So these incidentally detected cancers can affect the patient's survival, and the prognosis of this thyroid cancer is excellent, although with survival rates of 90% to 95% at 20 years. And here you can see the sonographic appearance of this carcinoma. You can see on a transverse view a 9 mm homogeneous hypoechoic solid lesion, and on the longitudinal view you can see another nodule with 7 mm size. It is homogeneous hypoechoic solid lesion that contains scattered microcalcifications. This is another image which is showing a solid hypoechoic lesion with lobulated margins. So just remember that a solid hypoechoic nodule that contains one or more of the malignant features would have 50 to 80% risk of being a cancer. And there is a minority of papillary cancer that can have cystic components, and these can overlap in appearance with the benign nodular hyperplasia. And this longitudinal view is showing the cystic nodule with septations and minimal solid elements, and this is basically a papillary cancer. So the minority cases can have cystic changes in papillary cancers as well. So the role of sonography in this cancer is basically the metastatic spread that can alter the surgical approach. It is recommended that the patient should undergo sonography 6 to 12 months post-operatively, and then periodically based on the risk factors. Okay, next we have the medullary cancer, which is basically derived from parafollicular cells, which are also called C cells. And these cells, we know that these cells secrete calcitonin, and therefore in this cancer we can use the serum calcitonin as a tumor marker. And this cancer basically accounts for 5% of the thyroid malignancy, and it has a more aggressive behavior than the other carcinomas, and it does not respond to the chemotherapy or radiation therapy. On sonography, you can see that the medullary cancer can appear as hyperechoic solid masses, and these can have microcalcifications. Microcalcifications are common in both the primary tumors and the nodal metastasis. And this cancer, on the color Doppler, it shows vascularity. So you can see that on the grayscale image, this is a hypoechoic nodule, a solid hypoechoic mass, and on the other image, which is showing the color Doppler, you can see that this nodule is vascular, and you can see the microcalcifications as well. Okay, now we will talk about the sonographic features of benign thyroid nodules, and we will also talk about the characteristics, the sonographic characteristics of the malignant nodules, thyroid nodules as well. So if on ultrasound you are assessing a nodule and it has following characteristics, then you would suspect it as a benign nodule. If it is well defined, if it has well defined margin, if it is thin, or it has complete halo, if it is solid, markedly hyperechoic, it can have cystic changes, but these should have thin septations, or they can have mixed solid and cystic appearance. And due to the calcifications, they can produce cometal artifact, and there is a characteristic appearance of peripheral eggshell calcification, which we will see in the next slide. There can be peripheral flow pattern on the color flow imaging, and these can be highly elastic on sonoelastography. This is how the eggshell calcification, peripheral eggshell calcification can be seen on ultrasound. Okay, now these are the characteristics which are related to the malignant thyroid nodules. A malignant nodule would have poorly defined or speculated margins. It would have taller than Y shape. It would have marked hypoechogenicity. It would have microcalcifications. It would have internal flow pattern on the color flow imaging, and it will be poorly elastic on sonoelastography, and there will definitely be cervical adenopathy associated with the malignant thyroid nodules. So that's all for today, and if you have any question regarding this lecture, then you can ask. Thank you so much.